Recording.
Welcome to this webinar. Let me just check everyone. Can everyone hear me?
Yeah,
we can hear you, Gareth.
Wonderful. Welcome to this webinar on the provision of extended care Tier 1 services. My name is Gareth McCaig from Community Pharmacy, Leicestershire and Rutland, or the LPC in Old Money. And the objective this evening is to show newcomers that getting ready to provide this extended care UTI service is not quite as clinically challenging as the SLA and PGD might imply, because the farm outcome system provides lots of detailed prompts to support you at every step of the way. So you don't need to remember everything. I will kick off with an overview of extended care services in the context of CPCS services, which you all will be familiar with. Then Paul Gilbert will come in and share an NHS England perspective on where pharmacist-led PGD services fit into the NHS primary care strategy. Then Maria Gilbert from the Leicestershire and Rutland Training Hub will give us a clinical refresher on the Tier 1 extended care services. Then I will round off with a whiz through some screenshots from farm outcomes, which guides the service delivery process that you will be working through. I would also like to thank Paul and Maria for supporting us this evening, and the LPC chairman for babysitting the little ones in the Gilbert household. So, what are the extended care suite of services all about? Their purpose is to alleviate pressure on GP appointments where specific conditions and symptoms can be deflected to community pharmacists that would typically require treatment with a prescription medicine. Extended care services could be considered to be an extension of CPCS services, which already respond to more minor conditions and symptoms with over-the-counter medicines. Nevertheless, whilst they have a lot in common, they are commissioned quite separately as an enhanced service across the NHS Midlands region. So, in a nutshell, CPCS services and its respective conditions are all treated with OTC medicines, whilst extended care conditions are all treated with prescription-only medicines. That's the key difference. And whilst the care pathways for patients and the referral processes from surgeries are quite similar, the actual service delivery process from a pharmacist perspective is quite different, since PGDs are necessary to provide a legal basis for the supply of treatments. As you can see here, there are currently 3 tiers of extended care services, with Tier 1 being the focus for this evening. As mentioned, this is a regional NHS pilot study. Service level agreements for these extended care services and the respective patient group directions are not available on the National Community Pharmacy England website, which was previously known as the PSNC. This was so to avoid confusing community pharmacies in the other English regions. So the paperwork for our East Midlands scheme is hosted by the Staffordshire and Stoke LPC website, the web link being shown here at the bottom of this slide. This is a screen snip of the Staffs and Stoke website, and I have starred the 2 key files, namely the service level agreement and the UTI proforma, which you can download. So, how do you get signed up to provide the service? First, download and print out the SLA and fill in your pharmacy details on page 4 and page 7. Then sign and scan or photograph these 2 pages and email them as an attachment to this email on the screen. The Extended Care Tier 1 module will then appear on your farm outcomes system on the left-hand side. You will then need to enroll when you first click on it with your GPHC number, and to confirm you have done CPP minor ailments, which you probably have done already, and read the UTI clinical knowledge summary. That's it. you'll be all good to go. Before I hand over to Paul and Maria, I would share this schematic with you to help clarify where extended care services fit in the overall primary care context. This illustration shows how the limited scope of the PGD can be thought of as a subset of the scope of what GPs can do, their actions in turn being restricted by the NICE guidance for managing UTIs. And beyond GP activity, it is over to secondary care. So when Maria goes through the clinical material shortly, she will indicate the content that falls within the scope of the PGD, and she will also indicate for your information where the content is outside of the PGD and typically requiring referrals onto other primary care clinicians. So I would hand over now to Paul. And Paul, you want to carry on with the context of the NHS strategy?
Yeah, absolutely. So thank you very much for the invitation today. And it's great to see such a fantastic turnout to learn more about what is a really, really valuable service for our patients, across LLR and the wider Midlands. I shall just share my screen now. This is part of a wider context around the importance of access to our health service in primary care. As I'm sure lots of you will be well aware, access has been a challenge in the NHS recently, is only getting worse currently, and will probably get even more challenging as we move forward. And so there have been lots of policy drivers that really have almost come after the launch of the extended care service, but actually the extended care service and the PGDs really do meet that the criteria. So a whole sea of acronyms there on the screen, and I've lost a little bit of formatting, unfortunately, but this is really well embedded in our plans and strategies for improving health and well-being of our patients across LLR, and particularly taking advantage of pharmacy's sort of key strengths around availability, access, and the skills of our pharmacy workforce.
Paul, should we be able to see your slides?
You should be, yeah. Can you not?
No, we can't see them yet.
Oh, let me try again. Is that sharing now?
Not yet, no.
So I'm not very familiar with Zoom, I'm afraid, colleagues.
Yeah, that's okay. So hang on, it's gone a bit. Yeah, we can see them now.
Okay, so let's move that up there. So a whole sea of acronyms and plans, which but community pharmacy and the increasing changes we're going to see moving forward as a primary care access and recovery plan really rolls ahead regarding community pharmacy delivering that that additional patient care for more complex patients. I'm sure all of us welcome that. So particularly around in LLR, we need to tackle that 8 a.m. rush that we know that a lot of our GP practices get. We want to make it easier and quicker for patients to get that help they need from primary care, and we do include community pharmacy as a key part of primary care. And we think that these services really do support the wider development and plans for primary care. Community pharmacy is a big part of that. The extended care service, and hopefully as that migrates into the common conditions service, to make a real difference for the patients in LLR. And then leads me into sort of where are we going next? What's the journey for community pharmacy over the next couple of years? Well, currently we know we've got CPCS, and in the Midlands we've got the extended care. but that's going to migrate into the common condition service, and that overall envelope and that basket of pharmacy first, those 9 services. So that there's 7 common conditions that are going to be linked to CPCS, the blood pressure check service and the contraception service. We can see huge ambition there from NHS England. This is linked to improved digital service requirements. We're doing some great work in LLR. So some of you will have heard the shared record presentation from our colleagues. And it's really about integrating community pharmacy to deliver those changes, make a real difference for our patients. And it's great to see so many people here going to make that journey, being part of provide that care. LLR is by far the strongest provider in the East Midlands of the extended care services, which is great to see. We're always one of the leading systems, and that's all down to the people on the front line, like yourselves, really making a difference to patients. So that's the big picture. I'm now going to hand over to Maria just to talk a little bit around the clinical side of UTIs in particular, and the other tier 1 service, acute bacterial conjunctivitis.
So, hi, I'm Maria. I work for the Leicestershire and Rutland Training Hub. I'm also an advanced clinical practitioner and a clinical pharmacist by background. I now work at DMU with postgraduate pharmacists and also undergraduates, but spent quite a lot of the last few years, last 17 years actually, in general practice, and the majority of that prescribing and supplying medications for acute illnesses and undifferentiated conditions, which we're not asking you to do. And I think that's something that Gareth really wants me to get across in this presentation is, let me just move Paul's slides on, sorry. He really wants me to get across that there is a background to this, and you know, we'll share that with you, and there's a bit of understanding and maybe a little bit of learning that you need to do, but the majority of this is, in fact all of it is within the PGDs and within the SLAs. They're really simple services, and the patients that you will be treating will follow those algorithms, and the ones that you are unable to treat will be excluded from your algorithm, and they're the ones that you need to refer on. So we just want to touch a little bit on the UTI and the conjunctivitis. So I'm going to start with the UTIs. So what kind of patients would come into your pharmacy, and what kind of symptoms would you be expecting to see? We've got strong, sudden and frequent urges to urinate, burning or irritated sensation when urinating, or maybe a patient would be feeling that their bladder has not emptied completely. So they might come in and say, oh, you know, I feel quite full. I go to the toilet a lot, but I'm unable to actually empty my bladder. A bit of pressure maybe in their lower back, or especially in their abdomen, so the front of their tummy. Thick or cloudy urine that may or may not contain blood. And these are the symptoms.
The little one just got eaten.
We've got somebody that's not on mute. So these are the kind of symptoms that patients might come into your pharmacy with, and may ask you for some treatment for your UTI. So we're looking at patients with uncomplicated UTIs, but we also need to think about what else could that be? What red flags are we looking out for, and what differentials do we need to consider? So although you've got a really simple algorithm to follow, just have in the back of your mind, you know, is this something else? And I think every pharmacist that I've met, every community pharmacist that I've met, especially in Leicester, would know whether the patient in front of them was unwell. You'll have done some sepsis training for this, and so you'll be quite familiar with the News 2 scoring system, but you don't need to go through that system to know whether you've got a patient in front of you who is acutely unwell. You can see that from that patient. You know, ask them, are they eating, are they drinking, are they passing any urine at all? And those kind of things will tell you whether that patient is acutely unwell. And once you've managed to rule out sepsis, just think, is it something else? Before I consider treating this patient for a UTI, what are they telling me? What kind of things are you getting from the history that they're giving you? So it's really going back to the history take that you learned at university, I suppose, and what that you do every single day, talking to those patients and asking about frequency, and if they got any hematuria. I suppose a lot of these things on the screen will be things that you will see in general practice. So you won't know if that patient's got a normal urinalysis, because it's unlikely that you're going to do a urine dip on a patient with no symptoms, because they won't be eligible for your service. So look at the patients that are eligible for your service spec. If there's no symptoms and they're outside of your service spec, you don't need to be dipping their urine because they're not eligible to be seeing you. But assess them for pyelonephritis. So if you've got a patient who's got really severe back pain and is talking about visible blood in their urine, then is this something else? So you need to be thinking, actually, is there something else that this could be? If they got a flu-like illness, or maybe really high fever, any nausea or vomiting, and if that's the case, then these patients need to be referred. But it's also about thinking where you refer these patients to. So obviously your sepsis patients, you're not going to be referring them back into your GP service. Your patients who may be presenting with appendicitis, because that can also cause frequency and pyuria. And urinalysis in this case can be a red herring. So these patients aren't going to be referred into a GP service. They're going to need to be referred into an emergency service. So it's about recognising those signs and being able to just differentiate between those patients that you do see. And 99% of the patients you do see will be uncomplicated UTIs. I'm just going to cover a little bit about over 65s. They're excluded from your PGD, and this really is a little bit about why they're excluded from your PGD. So there are notable differences in the approach to treating patients who are over 65. Men and women have the same approach when they're over 65, but there's also a high prevalence of asymptomatic bacteria, and that increases with age. UTIs are often blamed for non-specific presentations such as delirium, and patients who have dementia can't always tell you what their symptoms are. So these slides actually were originally written for clinical pharmacists and advanced clinical practitioners. So that's why it says always send a culture but don't dip. So again, you wouldn't be seeing these patients, but one of the reasons you wouldn't be seeing these patients is they are more complex and they're not the simple UTI patients that you'll be seeing. They don't fit into your simple algorithms. So under 65s, we treat our men and women differently. We treat our women first line with 3 days of antibiotics, nitrofurantoin, modified release 100 milligrams twice a day, ideally. But men will always have a 7-day course. And the reason for that is the length, the space that there is between the source of the infection and the exit site. So women, it's a shorter length of time, a length for us to treat, and we can hit that within 3 days. So they're pretty simple infections for us to treat in community pharmacy, quite easy for us to treat, and we'll get lots of women under the age of 65 who will come in with some really common symptoms, and they'll want to get treated and get back to work or get back to their daily life. And community pharmacy is the perfect place for them to be able to access this service. Just move on to the next slide. So just a little bit about men. Again, they're excluded from your PGD, but if you do see men and they do come in and they ask you, just exclude prostatitis or any kind of feverish illness that they may have, so that you know when you're referring these patients back in, or they know why you're referring them and what you're referring them for. Again, exclude pyelonephritis and sepsis so that you know where you're referring them to. Exclude epididymitis. So is there any severe pain, any possible twisting of the testicles? We wouldn't dip their urine necessarily in primary care anyway to rule out a UTI, but sometimes we would dip it to aid to diagnose them. quite often we will send a midstream urine for culture. But again, that's not something that you'd be able to do in a community pharmacy. So that's another reason that these patients would not be treated in community pharmacy. So refer them back, but know why you're referring them back and why we can't treat them. So, okay, so your initial assessment of your complex patients would be sort of localized symptoms of UTI. So you might present with a localized symptom of UTI with a high temperature, or maybe loss of diabetic control if you've got a diabetic patient. And up to half of those in long-term care facilities will have bacteria present, but they won't have a urine infection. So again, these patients will be complex patients that you won't be treating. It's not always harmful, this bacteria that we see in patients who are over 65 or in care facilities. And a positive dipstick doesn't mean that we need to be treating them with antibiotics. So we really need to be keeping away from some of those patients. So they're questions that really need to be asked, because we do have a lot of patients who are in care facilities who are under the age of 65 in Leicestershire. And the PGD in the service level agreement actually says ideally they should be seen face to face, but they don't have to be seen face to face. So it's about knowing who you're talking to and ensuring you're talking to the patient, making sure that your patient is not dwelling in a care home, and if they are, making sure that they're able to talk for themselves and that they're not a complex patient and they don't have any other complex conditions. So the majority of those patients, if they're in a care facility, will be ruled out of your PGD as well, and they'll need to be referred back into their primary care provider. So these are the patients that you are going to be treated. So women under the age of 65, 80% of women with vaginal discharge, though, will not have a urine infection. So talk to your women and find out what stage of life are they at. Do they have any discharge? Could this be urethritis? Could it be a sexually transmitted infection? Are they menopausal? And these are conversations that you have to get really confident and comfortable in having with patients. A lot of patients who are going around through the menopause will have quite dry symptoms, and they can cause symptoms that might be in line with the urine infection. So we need to be able to rule that out and exclude that first before we treat with antibiotics. And there is a massive long list in your PGD of patients who are excluded. So just make yourself familiar with that. But again, just keep an eye on it, and you've always got that to refer back to when you see your patients. There's no harm in talking to your patient, doing your initial assessment, and then just checking down your list and seeing actually, you know, are you eligible for the service, or do I need to exclude you from that? But consider the severity as well, and think, could this, you know, is this patient well? Are they well enough to go home with a 3-day course of antibiotics, or could they be suffering with sepsis? And also think about pyelonephritis. So ask them about pains in their back, ask them about visible blood in their urine, and ask them about symptoms that actually could be a little bit more severe than a UTI, because we don't always ask patients about these things, and sometimes we just jump to the most obvious conclusion, and that can be quite a dangerous thing to do in a way. But yes, they are uncomplicated urine infections, but sometimes we just assume that that's what it is because that's what the patient's told us it is. So just ask the questions and make sure that you're happy with your diagnosis before you prescribe. So this is how we generally diagnose a UTI in any setting for females under the age of 65. So not applicable for patients who have recurrent UTIs, but the ones in orange at the top are the most commonly thought to present a UTI, and they're the ones that have the most significance. So if you have 2 or 3 of those symptoms, there is no need to dip that patient's urine. 90% of your patients who think they have a urine infection and think they're coming to you to be assessed for a urine infection will bring a bottle of urine with them. If they have 2 or 3 of those top symptoms, then that urine does not need to be dipped. I suppose I'm not saying you can't dip it, and sometimes for for patient confidence. They may wish you to dip it, but it's when they've just got the one symptom that you really need to be dipping that urine to see if there is anything present. And that is to give you that diagnostic certainty. And then there's these symptoms on the side. So they're like other symptoms. So it says any new severe, so urgency, hematuria, frequency, or tenderness. So although they're key and common symptoms of urine infections, they don't have quite as much significance as the dysuria, the nocturia, or the cloudy urine. So if patients are presenting with those symptoms, again, you need to be dipping their urine. But if they've got 2 or 3 of the main symptoms, you don't really need to worry too much about the other symptoms. It's just if they've got none of the other symptoms, you need to be thinking about these symptoms. So if it's just the additional symptoms, you need to be dipping that urine. Is that clear? Yeah? Okay. So things to consider, and Gareth actually put a good slide on the next one just to show a urine dipstick analysis, because dipping urine can be used as an aid to diagnosis, but it's not actually how we diagnose a urine infection. So we look at the symptoms, and quite often in general practice, I would diagnose urine infection over the phone from what the patient has told me. And we didn't need to see those patients, and we didn't need to dip the urine, but it is an aid to diagnosis if you're not sure. So if you've got positive nitrates and or leukocytes and red blood cells, then a UTI is likely. If it's negative for leukocytes or nitrates and red blood cells, you need to be considering another diagnosis. So they're results that if you're referring that patient back to their GP, you might want to pass on to the patient. Obviously, they'll do another urine dip, but it's something that they may want in their preamble before they see that patient, so they know what they're looking at and they know what to expect when they see that patient, so they know to bring that patient in face to face. Asymptomatic bacteria, well, pregnant women, it says here, always treating pregnant women. Again, this is a slide for people within general practice that are prescribing. These patients are all excluded from your PGD. That said, however, if you see a patient who is pregnant, who says they have symptoms of a urine infection, you must be referring them because they need to be treated. Asymptomatic bacteria is rare in men who are under 65. And sterile pyuria is when you get white blood cell, so quite a high white blood cell count in the urine, but there's no sign of infection. It can happen after a patient has had a course of antibiotics for a UTI, so up to 2 weeks normally, or it can happen if you've got genital infections, so sexually transmitted infections, or renal abnormalities, renal stones, or just occasionally there will be an infection there, but there's just a non-culturable organism. So this is why we don't rely on urine dipping to diagnose a urine infection. And Gareth's put a dipstick analysis in here. What I would say is, I mean, this is quite good because there's a picture of it. There's a YouTube link there. It's definitely worth using and having a look at how you would dipstick it, because although it sounds like a really simple thing to do, and dipping urine is relatively simple, but it's about, holding that stick the right way around. If you've got it upside down, then the top of your stick is at the top of the screen where the leukocytes are, and it should be where the glucose is. And if you've got that the wrong way around, then everything else is going to be wrong. So you start off on the wrong foot. So you just need to know which way around you're holding it, what the gravity is of a trace blood count compared to a large blood count, or if you've got a negative nitrate count or a positive one, there's a very little difference between those boxes there. So it's just about recognizing those colours on the strips. So it's worth having a look at that YouTube link, and maybe getting some of the sticks out and having a good look at the side of the bottle before you start using them. It sounds like a really simple thing to do, but you've got a patient in front of you, and you've got to leave it for 60 seconds and then 120 seconds to look at your leukocytes. That's actually quite a long time whilst you're waiting for that to work. So it's just really a good idea to know what to expect. So next slide is just a little bit about patients with dementia, or patients So I suppose more in a community pharmacy setting, when you're looking at patients under the age of 65, those patients that might not be able to communicate or articulate their symptoms to you, so patients with learning disabilities. So asking a carer who may have helped with urination if they appear to be in pain. And it's knowing if you've got enough information about that patient to be able to diagnose a UTI alone. We often jump to a urine infection if a patient's struggling with delirium, and that's not always the case. So just being mindful of this, I suppose, and the pinch me mnemonics quite good to identify potential causes, other causes of delirium. So is there any pain or infection? Are they eating well? Are they constipated? Sometimes the urine infection in a patient who's non-verbal can show up, constipation can show up as a urine infection or another infection. Are they being well hydrated? Because if they're not passing urine, or if they're passing strong and smelly urine, it might just be because they're not hydrated enough. Medication or the environment that they're in. So again, care home patients. So just have a think about that when you're seeing patients. And then you've got this bit about your exclusions from your extended care PGD. There are lots. This is just scrapes the surface. But men, I don't know why. I think for this slide for you, I don't know why it says 16 plus. Men in total, all of them, not just 16 plus, but all men. Recurrent upper UTIs, recurrent lower UTIs of unknown causes, pregnant women, under 16s and over 65s. And then think about your red flags, so suspected cancer. So you need to be referring the following to general practice for a 2-week wait pathway. So that pathway is a pathway that the general practitioner or a clinician within the GP setting will send that patient to, and they will ensure that they get an appointment date within 2 weeks of the referral being sent off. So if they're over 45 and have unexplained blood in their urine and no urine infection, you need to be asking them to head straight down to their GP on that day. Again, visible blood recurring after a successful treatment of UTI. So if you've treated somebody and they come back and they've got blood in their urine and it's visible, you need to be referring them to their GP on the day. Over 60 years, so not over 65, but over 60 years, so it does fall within your remit, but unexplained non-visible blood, another dysuria or raised white cell count, that actually probably wouldn't come to you, because if they've got no symptoms, it's unlikely that they would fit into your service spec, so you wouldn't really be seeing them. 60 years plus non-urgent, recurrent or persistent unexplained UTI. Again, if it's recurrent or persistent, they would be out of your spec anyway, so you shouldn't be testing that urine. So just a bit around the antibiotics that we use and why we use them. So first choice antibiotics for UTIs in LLR, we follow the local area prescribing committee guidelines, and it's nitrofurantoin, 100 milligrams twice a day for women of all ages that you'll be treating for 3 days. Then your second line treatment is nitrofurantoin, 50 milligrams 4 times a day for 3 days. Okay, and if their EGFR, I think, I'm not sure, is it the next slide? Yeah, so if their EGFR is below 45 and a lower UTI is suspected, then we shouldn't be using nitrofurantoin. Gareth and I were talking about this earlier. You don't have the information or the blood results to know what EGFR these patients have. So if they talk to you and they say, I think I've got kidney disease, then they fall outside the spec of your PGD. And it might come back that their EGFR was over 60, but that's not your problem. You knew that patient had kidney disease and it was an underlying condition. It complicates the situation and it means that you can't treat them. Okay, so again, over 65s, refer them back because asymptomatic bacteria is common, and exclude any sepsis and pyelonephritis. I don't think I can say that enough. Just got a quick case study here. I'm not quite sure how to access the chat in Zoom. Oh, here we go. Right, so a 32-year-old non-pregnant female presents with dysuria and new onset severe frequency. She denies any vaginal discharge and she's got a penicillin allergy. How would you approach it? Would you dip the urine, supply nitrofurantoin under your PGD, prescribe trimethoprim, or refer back to GP or refer to A&E? Do you want to pop in the chat? That's what you would do. Fab. Okay, everyone's read the PGD. So yeah, perfect. So you supply the nitrofurantoin under PGD. What would you do differently? Would anything be different if she was 16 weeks pregnant? And if so, how? Do you want to pop that in the chat for me as well? I just want to make sure I've been clear. Brilliant. Yeah, so everyone's going to refer to the GP, and that's, yeah, absolutely perfect. And there's a slide here that I think Paul's going to jump in on. So that's it really for UTIs. So just to say, UTIs they're simple. And in general practice they're simple. Primary care they're simple. There are very few cases that need to be passed out to urology. We have a lot of elderly patients, but your practices should know not to refer those patients to you. And obviously, if those patients turn up to you, you know that you can tell them that you can't treat them. But it's not rocket science, and there's no kind of trickery or there's no magic behind it. It's easy. It was when I was working in general practice. It was if I had like 4 or 5 UTIs in a row on my ledger, I felt like I was winning because that was an easy day for me. They are simple and they're easy to treat, and 99.9% of the time you won't see that patient back. So it's something that for community pharmacies, it's an easy win really from my point of view anyway. But I'm just going to pass you over to Paul for this slide here.
Thank you, Maria. So you can see on the slide a single sheet which we recommend that you use to discuss the service with colleagues in general practice so that they know who's suitable to refer. So obviously, hopefully the green side suitable to refer, red not suitable to refer. Does it include the whole of the extensions and excuse of the PGD, but should cover most patients most of the time. It's just a real tool to take to reception, take to local practice to explain the service, and then to really engage them in sending those patients directly to yourself. I've also got as hopefully some of you have seen this, it's been sent out from the commissioning team, just a guide on sort of running the service, got QR codes around availability of which pharmacies are signed up. We do really, really strongly encourage that, if you signed up to deliver the service, that it is available, if possible, all the time you're open. But if not, make sure the rest of the team in the pharmacy know. The preference is to signpost patients to another pharmacy that offers the service rather than sending them back to the GP. So really to encourage you to try and keep those patients within community pharmacy, because I think as a sector delivers together, it really does demonstrate the capability and really supports that patient care. I'll just hand you back to Maria.
Okay, so just a little bit on conjunctivitis. So I'm probably teaching you how to suck eggs here. So signs and symptoms of recognising conjunctivitis. So you've got pink eyes, and you've got an inflamed conjunctiva, so the eyes are slightly inflamed. Most of the time it's viral. Sorry, let me put my teeth back in. It's usually viral. Majority of adults, it will be viral. It's more often bacterial when we're looking at children. and the PGD covers patients who are from 3 months to 24 months, I believe, and then obviously after 24 months you can sell this product. So it's a self-limiting condition that normally goes away or improves on its own, and I think that, well, I suppose the main reason that you can't treat 0 to 3 months is because newborns are at quite high risk of this bacterial form of ophthalmia neotorium. So it's even a lot of the under 2s that you treat will be a viral case, but parents are often quite alarmed by a red eye, a swollen eye, or a gooey eye in a child, and would like something to treat it. So antibiotic eye drops are often prescribed for children under the age of 2, and that at the moment a lot of the time goes for general practice because we don't have many pharmacies that are supplying this on PGD, and it would be fantastic if we could just increase that uptake. So it's the diagnosis really is just basic examination. Again, the PGD does say ideally that you would be seeing the patient, but it doesn't say that you have to see the patient. So if you can't do a basic examination, you've got to take a really good ocular history. So you're taking that from the parents because you can't really talk to this 2-year-old. So you want to know the onset, and it needs to be, to fit into your PGD, it needs to be 3 days or more. So because it's a self-limiting condition and quite often viral, by 3 days it should have improved, and I suppose that's the point at which we're thinking, oh, actually antibiotic eye drops may help. So red flags would include contact lens wearers, which you're not going to get in your 3 months to 2 years, hopefully, but pre-existing eye conditions you possibly could. So your treatment would be your chloramphenicol eye drops or your ointment as first line, and then just practical advice, so cleaning the eyelids and using cooling compresses. But there's really no more to it than there is in supplying your OTC chloramphenicol, apart from the fact that you're changing your age, and I suppose you're a bit more mindful because the patients that you're treating can't communicate with you, and that makes it a little bit more complex. So the red flags would be severe eye pain or vision changes, pre-existing eye conditions such as glaucoma, suspected involvement of sexually transmitted infections, contact lens wearers, pregnant or breastfeeding mothers. So they're all your usual red flags. And then I put here children aged under 2 for OTC treatment. And I think Gareth just wanted me to explain why I'd said under 2 is a red flag. Maybe red flag was the wrong word for it, but children under the age of 2 have a higher incidence of bacterial conjunctivitis. Once they reach 2, it's normally a viral self-limiting condition. And also they are less able to articulate the above, so they can't tell you if there is severe eye pain or whether they've had a vision change. And we won't always know whether they've got eye conditions. Obviously, we'll know whether they're contact lens wearers, and hopefully there'll be no STIs. But there's just that little bit of unknown around these patients. So it's about, hopefully you'll be able to see your patients rather than taking your history from a parent. And I would explain to the parents that that's what you want to do. If they ring you and say, can you treat my child? Then ask that they bring them in so you can have a look at the eyes, and just try and take cues from the child themselves. While they're screaming, do they look in pain, or are they rubbing the eye? Is it both eyes? Because the next slide is about deferred prescriptions, and if it's both eyes and it's sort of hay fever season and it's just been a few days, could it be a case of hay fever in a young child? And if you've got a child over the age of 1, could you sell some Piriton? Is that, if there's no other symptoms there, is it something else? This is where we start to think about the differentials again. Could it be something other than conjunctivitis? If it's really mild, or if it's not been there for 3 days, again, that might be where you think about deferring your supply. and thinking about doing, there's a part on the form, on the farm outcomes form, where you can defer the supply and then do the consultation. The patient can come back after the 3 days. So say they've only had it for 24 hours, and you say you need to have had this for 72 hours, and they come back after 72 hours and say, actually, no, it's not got any better. Then that's when you could use this deferred supply section. Also, if your symptoms are already improving, you can do your consultation, but it might not be appropriate at that point to supply an antibiotic, because again, it's probably viral, or it's going to self-limit and it's going to go away. So just be mindful when you're treating children, if they look particularly uncomfortable, or they're not opening their eyes, they're not able to open their eyes, then that would be a red flag. But otherwise, conjunctivitis would be treated in children very similar to adults, as long as there's no like really copious amounts of discharge and anything that you're particularly worried about. You can treat them as normal patients with conjunctivitis. And I think that's the end of my slides. There's a blank one here, Gareth.
Okay, so if you close yours, please.
Yeah. Stop sharing. Okay.
That's wonderful. Okay, so just someone let me know if you can hear me.
Yeah, we can hear you.
Wonderful. So in this final section of the webinar, I will fly through the various farm outcomes pages that you will see when you provide the service. My objective here is to let you see, let me just see, 1 second. Bear with me. Okay, apologies for that. So as I said, my objective here is to let you see how much support farm outcomes actually provides, because you will be very relieved to know that you don't need to remember everything that you've heard this evening. You just need to be relatively conversant with the issues, and the farm outcomes system will prompt you to make sure you don't forget anything. So don't take any notes as I go through these next few slides, because you will see all of these pages on the farm outcomes system when you enroll yourself into the service. This is the first screen when you're presented with a patient. You have to register the patient into the farm outcome system first to confirm the patient is registered with the GP in the Midlands region. So before you, whether it's a UTI patient or an acute bacterial conjunctivitis patient, doesn't matter. The first thing that you do when a patient presents for an extended care service is you've got to register them into the extended care system. So this is the page that you will see, you've got to deal with this first. So there are some simple tick boxes simply to follow, supported with all the information you need. So just have a quick look at what's on that screen. Copious amounts of information, lots of it lifted from the PGD and the service level agreement. You don't have to remember all of this stuff because it's going to be right there in front of you. Next, you must identify the surgery that the patient is registered with, and it will tell you if the surgery is within the Midlands region or not. A very important part of the service is the 7-day follow-up. You must secure permission from the patient, permitting you to contact them after 7 days. Crucially, the pharmacy claim for payment is triggered by the completion of the 7-day follow-up. So if you provide the service, the main intervention, and you don't provide the 7-day follow-up and save that, you will not be provided, you will not be paid for the service. And last time I looked, there was about 41 units of service that had not been claimed for in the last quarter, which is significant. So make sure you record the patient's contact details. The system even prompts you to do this with a free type box to take some notes. You also have to give the patient an information leaflet, and there is even a link here to print one off as you go through the process. So you've registered the patient, you've identified their surgery, they're definitely a Midlands patient. Now you can crack on and provide an extended care service. If it's a UTI service, then it's the second one down on this screen. You would click on there simply. Straight into the inclusion criteria for UTI. All of the inclusion criteria are set out there in front of you. It also refers to a Public Health England flowchart, where I've put the star, which is a very helpful document. I've just added it onto the screen on the left-hand side. I would recommend you print that out and keep it in your file. This next page is where you enter the symptoms which the patient is experiencing. It is so very straightforward. So given all of the material that Maria presented, the stuff that I've shared already, it all boils down to this one page, if you like, on farm outcomes. And you tick the boxes as appropriate, and the system will guide you as appropriate, whether dipsticks are required, for example. A quick mention here of the UTI pro forma, which you can use if farm outcomes is down or the system has crashed. Note especially that there have been several versions of this pro forma issued during the pilot study so far. So my advice is to use the specific UTI pro forma link on the Staffs and Stoke website to locate this correct version. And I've indicated here in red. The correct version gives 3 diagnostic signs. Some of the earlier versions had 5 box options. It's this 3 diagnostic signs that indicates it's the correct version, and it's on the Staffs and Stoke site. You cannot go wrong if you have to do a dipstick, because all of the information, again, is on the screen right in front of our eyes. You don't have to remember everything. It's not like swatting up for a final exam. The key learning point, which I think you might have observed by now, is that farm outcomes will remind you of the issues as you progress through service delivery. You're prompted, you just need to be conversant. So yeah, tackle that CPP material, read the CK clinical knowledge summaries, but you don't have to get ready for a final exam question. You just need to be conversant. You don't need detailed recall, because this system will provide all the prompts that you need. You just need to have read through the material and understood it. And then when you come to provide the service, it will be very straightforward. Everything is there. And here's the final checklist before you finish the service. Have you done this, that, and t'other? It's all there, including consideration of the levies, if you've taken that or otherwise. Just record the outcome of the intervention, and a reminder if you've given out the various leaflets, just check the boxes and the exemption status, which is a drop-down box there. Finally, I would just revert briefly again to this referral guidance for surgery receptionists. Please note it's designed to filter out the most basic inappropriate referrals, which will mean that there will be fewer incidences of referrals back to the surgery. My advice is for you to give copies to your surgery reception teams and to quickly run through it with them, as it will develop their confidence when making referrals to you. And my last slide here, just a few miscellaneous points. Didn't know where else to put them in the presentation. So number 1, pharmacists can promote extended care services which they provide directly to patients, a bit like promoting the NHS EHC services. So Maria's coverage of excluded symptoms will be useful if you've got walk-in patients asking for a UTI treatment, because those patients will not have been filtered via the surgery reception team. Another key point, the second point here, is to ask surgeries to ensure that any referrals that they make to you is done electronically, for example, by NHS mail. Drag old referrals into a folder and retain to support post-payment validation of claims. Post-payment validation of claims is something that's on the horizon. And if you've received electronic referrals, don't delete them when you finish them, drag them into a file. And referral back, we've mentioned that they will happen. Put the processes in place. I would suggest a similar process as referring CPCS referrals back. And finally, remember those 7-day follow-ups. If someone had hematuria, ask at the 7 days point if there's any visible blood remaining, if it was mentioned initially. Other symptoms might have resolved, but if the blood's still there, again, that's a referral. Remember what Maria had said. And I think it's 5 to 9. We've got 5 minutes left for Q's and A's. Can I hand it over to you, Rashri, to reflect on Q's and A's if you're there?
Yeah, that's fine, Gareth. I'm just going to have a quick look. I think you've answered some of them in terms of, there's a couple of questions around how many UTI treatments can a patient have in a year, but I feel that you've both answered that already, so that's fine. In terms of, I think there was somebody that asked the question, when will this appear on Pharma Outcomes? I'm hoping that last segment has answered that question. Obviously part of the sign-up process as well. Feel free to add in the chat. Sorry, things are moving up as I'm trying to find the questions and answers. There was another question around, is this recorded? And yes, it is recorded, and it will be on the website, certainly by the end of the week, I suspect, on our website. So we'll circulate the link with you via WhatsApp and email that we normally do as well. I think, how can we access the recording? Sorry, every time I'm looking at it, it won't probably be done tomorrow, but we can ask Kate, to put it on, but we'll certainly share the link with you all. There was a couple of questions. Yes. How do we stay updated was a question. Now, I'm not sure that was something, I don't know who's that from, but in terms of any social media groups, I'm not sure who's asked that, but I'm struggling to understand what that question is relating to, whether it's about the extended care service or whether it's just about in terms of how do you stay up to date with the goings on within the LPC, because we do have quite a lot. So if you want to come back in to iPad, and I don't know who that is because nobody's put their name on, feel free to make yourself known. There was a question here, is visible blood referral back to GP, presumably talking about UTI? Is that a referral back to GP?
Sorry, I've just popped something in there, but I don't know if it's actually posted. So not, has it posted? I don't know if I've managed to answer that. So not immediately, no, but if it doesn't resolve after 7 days, then it would be. Or if it is just visible blood and there's no other signs of UTI, then that's a referral. But it is one of the signs, and it's one of the symptoms of a urine infection. It's not one of the most common symptoms, but it is a symptom of a urine infection that we can count as one of the other symptoms. But that's when you would dip the urine, and if there was no other symptoms and that only, then you'd send it back to the GP. But if you got, say, dysuria, nocturia, hematuria, so blood in your urine, then you could treat that, and if that resolved within your 3 days, then that's fine. If it's still there, then that would be a referral into the system, back into the GP. So I suppose that's a safety netting thing. And somebody put something, but I can't find the question now, about not treating diabetics, but they assume that will be excluded from your PGD because they're higher risk. of they're likely to get, or quite often, once diabetes is uncontrolled or not so well controlled, they're more likely to get urine infections. So that's something we want to be picking up at the source. But also it can be, as everyone will know here because we're all pharmacists, but it can be a side effect of some of our common newer anti-diabetic drugs as well. So I imagine that's another reason that they're not included in the PGD, because some of our anti-diabetic drugs, if we dip their urine, it will show glucose, and that would be a red flag to some people. But actually, if you're taking, I don't know, dapagliflozin, then that's normal. That's how the drug works. It excretes glucose through the urine. So that's one of the reasons, or a couple of the reasons, you wouldn't be treating diabetics in pharmacies. And I'm not sure about COPD and asthma, but I assume they're just, are they excluded, Gareth? Is it just because they're chronic conditions?
Yes, there's a whole list of chronic conditions.
Yeah, I was going to say there is a massive list. So yeah, and they're probably just excluded because they're chronic conditions.
Brilliant.
So,
Thank you.
Could I suggest, ask people on the webinar to please indicate if this contractor support model was useful to you, perhaps with a yes for yes, you agree it was useful, or no, you're no further on having listened to this. So please could I ask everyone to put a yes or a no, and I would secondarily ask, please give us any additional feedback beyond a yes or no if you've got a few moments just to share. So yes or a no, please. Some more information if you care to provide it. Thank you.
Thanks, everyone. Just trying to find the questions as well. And as everyone's typing, I can't actually see the question. So great that you all find it useful, but I just need you to stop so I can look at the questions, because it's just moving up and down, so we won't stay still. So there was a question around, I think somebody was asking if, I think the gist of it was one for you, Gareth, if somebody wants to sign up but defer that, I believe, defer from starting it, can they sign up but defer to start until January? I guess Common Condition Service is going to have something to do with it as well, I suspect.
Yes, you can. So you can sign up. There's a grace period. I'm getting an echo there. So yes, you can follow the signing up and the enrollment. If you're not feeling competent because you want to do a bit more study, the issue is not actually engaging a patient and providing a service. So sign up to the service, get the pharma outcomes module onto the extended care module onto your pharma outcome system. Then you can play with it. You know, you can invent some patients, put some symptoms in there. Just don't save it at the end, so you can have a play with the system, but you can only do that after you've registered to provide the service and then enrolled. So don't aim for a service until you're feeling competent.
And there was another question: if treatment is 3 days, do we still need to call, make the 7-day call? What happens if fail to respond to call? So what happens if the patient
there is a consideration for that. You've got to attempt 3 times, and if you cannot catch the patient, then you indicate that they were lost to follow-up, and then you will be paid. But that would be the content that you would put into the 7-day follow-up, that they were indeed lost to follow-up. At that point, you will have completed the 7-day follow-up obligation, and then the payment will be triggered.
Brill. Thank you. If there's any more questions, feel free to raise your hand. You know, you've got an expert panel here tonight, so please do make the most of this opportunity to ask the expert panel. So give you a few moments to gather your thoughts. Just have a look if there's any hands up. No questions for Gareth and the team. Somebody's just written in the chat, Dummy's Guide for Locums, I suspect. Worried about enrolling and appearing to surgeries. We offer the service. Oh, okay, so thank you. somebody's just put in the chat, Gareth, worried about enrolling and appearing to surgeries public. We offer the service, but we still run on locums and might not necessarily be trained. So I think there's something around, could we do a dummies guide or a guide for locums, just to support them on training? But I guess it doesn't matter whether you're a locum or a pharmacist, the guide's the same. There's nothing specific for a locum that they should or shouldn't do because they're a locum. And we've really steered away from that as an LPC as well. Okay. There was another question, which dipstick do you use?
It's usually multi-sticks, it mentions that, but it does say in the pro forma that you can use any appropriate dipstick that tests for nitrites and leukocytes. The 3 or 4 things are specifically mentioned. It says refer to the manufacturer's guidance if you use a different type of diagnostic stick.
Yeah, thank you. And then there's just an issue with somebody having just changed ownership in June to their pharmacy. How do they sign up for the SLA? So if you want to just add your contact details in the chat, if Gareth can reach out to you, maybe that'd probably be better, because I think that's going to require a little bit more hand-holding. But we're happy to support.
I think it's simple. When you get your new ODS code, at that point, you complete that page 4 and page 7 of the SLA, get that sent off. And with that new ODS code, they'll be able to put extended care tier 1 onto your farm outcomes system.
Yeah. Thank you. And then another question, Gareth, does payment for UTI cover the cost of the dipstick?
I can't remember. That's the one thing. I saw that coming up there. I don't know, but I will make mention of that in the material that I pulled together for the website over the next few days. Sorry, I don't know the answer straight off.
That's fine.
It's worth mentioning what the fee is. So it's £17 for providing the service and £20 if you make a supply plus the cost of the medicine. So it's in most cases there will be a supply, so it's £20 a supply. But remember the 7-day follow-up, because you get nothing.
Yes.
If you don't do that.
Just a question about consultation room. Does the consultation have to be in a So does the consultation have to be in a consultation room to claim for an extended tier service, or is it claimable as an OTC?
Well, I wouldn't know.
Is it claimable?
You won't know if something like a stick test is necessary if you start a conversation at the chemist counter. So I wouldn't want to have this conversation, especially if you're getting into possible sexual activity and all sorts of things. So I wouldn't provide this service unless it was in a confidential consultation room.
And there's just another contractor saying that they used to offer the tier 1, tier 2, but they've been removed from farmer outcomes, and they're not sure how to get back on. So again, do you want me to, or perhaps they should reach out to you directly on that one, because we'd need to investigate why you've been removed and just understand what's gone on there. I don't think we can give you a blanket. Yeah, I don't think we can give you a blanket answer on that, to be fair. I think we'd need to look into that. And sorry, things are moving up. That's fine. I think we've answered all the questions. So
just to say that we're hoping to provide another one of these for tier 2 at some point in the near future. We've got a few things coming up, not to mention Christmas. So we've got the discharge medicine service. We're going to be doing something on that in the new year. If we can squeeze another one of these in before Christmas on tier 2, then we will watch this space.
Lovely. Well, thank you, Gareth. Thank you, Paul and Maria as well for tonight. Certainly found it really useful. Great attendance from contractors. So thank you for taking time out on this. In terms of how you can stay up to date on these webinars, well, we always send out reminders or announcements of when the webinars are happening, and there'll be a diarised and serial of reminders up to and leading up to the day or on the day as well. You can also check out our events page on our training page on our website. We put information on there as well. We also put it on our WhatsApp group. So if you're not part of our WhatsApp group, we share the flyers on there in terms of the training events as well as the login details as well. If you still can't find it, then feel free to reach out to myself or Gareth and we'll be happy to point you in the right direction. If you want to send me an email or pop your email, send me a quick message, I can add you onto the WhatsApp group. It's as easy as that. I just need your mobile. Okay. Brilliant. Well, thank you so much. Conscious of the time, it's gone 9:10. And great that you've really enjoyed it and found it useful. And thank you for the comments. Well done, guys. Thank you.
Thank you.
Just need to take a picture of this.
I've just sent you a screenshot and I've saved all the chat as well.
Oh, thanks, Kate. I was trying to struggle getting the picture of the...
Yeah, I've just emailed it over to you, don't worry.
Oh, thanks. Thanks, everyone. Don't know if you want to stay on for just 5 minutes, Gareth.
Yes, and Paul's still there as well.
Yeah, perfect.
Is Chairman Bale still there and Altaf and any other committee members?
Just wait for the others. If not, I'll pick them up. Okay, you might just want to